Welcome to everybody. I am Cristina Dopazo, a liver surgeon in Hospital Valdebrón, Barcelona. It's a pleasure for me to moderate this webinar organized by DSO and the Spanish Society for Surgical Oncology. Today we come with an international expert panel to discuss the role of adjuvant therapy in the multidisciplinary approach of resectable and borderline resectable cholangiocarcinoma. The aim of this webinar is to provide different tools for adequate surgical strategy in the management of intrahepatic and periliar cholangiocarcinoma, mainly with RS0 intention. After that, I will present a short clinical case open for discussion. Hope you can do a lot of questions. And just to introduce our expert panel, it will be Dr. Elena Verdaguer, medical oncologist in Hospital Valdebrón, Dr. Francesco Cellini, radiation oncologist from Catholic University of Rome, both experts in the HPV area, and Dr. José Manuel Ramia, in representation of the Spanish Society of Surgical Oncology, chief of the General Surgery Department in Hospital General de Alicante, and with a huge background in HPV surgery, co-leading different national and international studies in HPV area. So just to let Dr. Elena Verdaguer give us her oncologist's point of view in the treatment of cholangiocarcinoma.
Hello, thank you very much for inviting me to give this presentation. I will talk about neoadjuvant treatment strategies in cholangiocarcinoma from the medical oncologist point of view. First of all, let's see the epidemiology of cholangiocarcinoma. Cholangiocarcinoma is not a very frequent disease. It's more frequent in Eastern countries than in Western countries and has a poor prognosis with a 5-year overall survival rate of less than 20%, taking into account all the stages. It's often diagnosed at advanced stages, and in those diagnosed in early stages, it has a high relapse rate. So looking at this more in detail, in patients with intrahepatic or periliar cholangiocarcinoma, 40% of the cases are diagnosed in resectable stages and 60–70% in unresectable. So in those resectable stages, we can offer to our patient resection and adjuvant chemotherapy, achieving 5-year survivals in R0 resection of 40% and of 20% in those with lymph node involvement or vascular invasion. In those diagnosed at unresectable stages, we can offer systemic treatment or local regional treatments, achieving median overall survivals around 12 months. So let's see the adjuvant treatment. There are different trials that have been conducted in this setting. The BILCAP trial is the first that shows an improvement in overall survival, so I will present you this trial. In this trial, patients with cholangiocarcinoma or gallbladder cancer with complete resection were randomized to receive adjuvant capecitabine for 8 cycles versus observation. The primary endpoint was overall survival. More than 400 patients were included, and different localizations of cholangiocarcinoma were included. There were also a representation of R1 patients and also N1 patients. And looking at the results, there was a difference in overall survivals with 51.1 months in the capecitabine groups versus 36.5 months in the observation groups, but this was not statistically significant. But nevertheless, in the planned sensitivity analysis in the intention to treat population that was adjusted for lymph node involvement, grade, histological grade, and sex, this difference was statistically significant. In the per protocol analysis, there was a difference, and this was statistically significant. If we look at the analysis of the recurrence-free survival was also better for the capecitabine group, and this was statistically significant. Nevertheless, there was a high proportion of patients that had recurrence. It was 63% in the capecitabine group and 65% in the observation group. This shows us that we have still a lot to improve in these patients, and that although we give the best treatments that we have in combinations with surgery and adjuvant treatment, we still have a high proportion of disease relapse. So we have to look for better strategies. One of these strategies could be the neoadjuvant treatment. This neoadjuvant treatment have some advantages and disadvantages. Let's see it. One of the advantages of neoadjuvant treatment is that it can act on micrometastatic disease. This would improve the distant relapse. It can improve the surgery by reducing tumor volume, and this could improve the R0 resection rate. And it can also select those patients who have a more aggressive disease, and then perhaps in them we can avoid unnecessary surgeries. Some of the cons of the neoadjuvant treatment are that we need a biopsy, we need normal bilirubin levels, and this also takes time, and that we have limited data. We don't have phase 3 trials, and most of the data that we have are retrospective and often single institution series. Let's see at some of these data. First, I will show you two series of unresectable cholangiocarcinoma. In this series, 22 patients with unresectable cholangiocarcinoma were treated with neoadjuvant gemcitabine. And of these 22 patients, 8 patients were resected and 4 patients achieved an R0 resection. Another series is this French series in which 74 patients with locally advanced intrahepatic cholangiocarcinoma were treated with neoadjuvant chemotherapy. In this case, there were combinations of gemcitabine-based regimens and also the combination FOLFIRINOX, and 39 patients could achieve a resection. And also another retrospective study that has been published is this large retrospective cohort is from the national database in the USA with more than 4,000 patients. And in this series, 607 patients received neoadjuvant treatment. If we look at the survival analysis, there is a better overall survival in those patients that received neoadjuvant treatment, and this survival was better in those patients that received multi-agent chemotherapy and that received neoadjuvant chemotherapy that included radiotherapy. So these are some of the data that we have. They are mostly retrospective, and we should generate more data. To generate more data, first of all, we have to decide which would be the best systemic treatment that we can offer to our patients. And to offer this good systemic treatment, we have to understand these tumors. And we know nowadays that these tumors are very heterogeneous, that some of them can have molecular alterations that can be treated with targeted treatment, and we have good results with targeted treatment that I will show you today. And we have to individualize and to analyze this patient in groups, taking into account its biology. So if we look at the evidence that we have in systemic treatment, for the first line setting, there is only one positive phase 3 clinical trial, that is ABC02 trial. In this trial, more than 400 patients, and here we had cholangiocarcinoma, gallbladder cancer, and ampullary cancer, were randomized to receive cisplatin and gemcitabine versus gemcitabine alone. And it was a positive trial for overall survival, with a median overall survival of 11.7 months for the combination arm versus 8.1 months for the gemcitabine arm. And this was statistically significant. If we look at the overall response rate, and this is important for the neoadjuvant treatment, there was a 26% of overall response rate in the combination group. Regarding chemotherapy, what is being researched now? We have now trials that are evaluating triplets. For example, the combination of cisplatin, gemcitabine, and nab-paclitaxel, that in a single institution trial has had very good results with an overall response rate of 45%, and that now is being evaluated in a phase 3 clinical trial comparing with the standard of care, cisplatin and gemcitabine. We are also evaluating new chemotherapy strategies like NUC1031, that is a new formulation of gemcitabine that avoids the cellular metabolism, and that is being evaluated in combination with cisplatin in a phase 3 clinical trial. Other strategies that we are evaluating now, one of them is immunotherapy. We know that there is a group of patients that could respond to immunotherapy, and the trials that we have that are being conducted are combinations of chemotherapy, the standard of care, cisplatin and gemcitabine, with immunotherapy. We have different trials, and one of them, TOPAZ-1, is now finished and has results. We know that is positive, and we are waiting for the definitive results that I hope will be presented in the next ASCO GI. Other strategies I've already mentioned are the targeted therapy, because there is a great proportion of patients that can have molecular alterations that can be targeted with targeted treatment, and we have some very good results in this field. For example, 15% of the patients have FGFR2 alterations, and we have some phase 2 clinical trials that have demonstrated very good overall response rate in very pretreated patients, going from 20 to 35% of overall response rate. Some of these compounds are now being evaluated in first line, in phase 3 clinical trial, and we will see the results later on. Another target that we are that has been evaluated is ADH1, and the compound ivosidenib, or AG120, has been evaluated in a phase 3 clinical trial, being a positive trial with an improvement, or a modest improvement of PFS versus placebo. Other alteration and other targets that we have for cholangiocarcinoma are BRAF inhibitors. We know that less than 10% of the patients can have a BRAF mutation, and that we have very, very good responses when we treat these patients with BRAF inhibitors, and nowadays we are treating metastatic patients with these combinations. And we have also other alterations. As I told you, there is a great proportion of patients that can have targeted alterations and that can be treated. For example, DNA repair genes sometimes are altered, or we have other less frequent alterations. For example, TRK fusions that have very good responses with TRK inhibitors. And what are the trials that now are being conducted in the neoadjuvant treatment? So most of them are phase 2 clinical trials. Combinations of chemotherapy like triplets are being conducted. Also, combinations of chemotherapy with immunotherapy are being studied, and also immunotherapy with TKI inhibitors are being conducted. So we need these trials. We need trials that take into account the complexity of cholangiocarcinoma, and that take into account also this broad tumor that has so different subgroups of patients. So to conclude, neoadjuvant treatment is a promising approach, but needs validation in prospective trials. It may improve R0 resection, it may improve recurrence rate, but we have to know that we need pathologic confirmations, we need normal levels of bilirubin that sometimes need time to be achieved, and clinical trials in this setting should include combined approaches. We know that it's better to give multi-agent therapy than monotherapy, and we should include molecular selection, because we know that is needed in this tumor that has so many targeted treatment, and subgroup analysis to better understand which patients benefit from this treatment. So prospective randomized trials are needed to implement this strategy. So thank you very much.
So thanks, Dr. Verdaguer. It was a very great updating of the chemotherapy therapies. So just a question, because looks like that we are very far away from results, for example, in pancreatic cancer setting, that more and more we're talking about neoadjuvant therapy in these cases. So because the problem in cholangiocarcinoma resection is the early one resection that impact very negatively in survival, which is the handicap to give to all these patients neoadjuvant therapy. Could maybe, as you said, decrease in size, to have more opportunities to get a R0 resection. What is the main handicap of neoadjuvant therapy in cholangiocarcinoma setting?
So for me, in the clinical practice now, is the lack of evidence. So we need more evidence to give those patients neoadjuvant treatment. So we need more prospective trials. And had we had these prospective clinical trials, I would say that perhaps in intrahepatic cholangiocarcinomas can be easier to give neoadjuvant treatment, because are lesions that are accessible, that usually patients do not have increased bilirubin level, so it can be fast and easy. But I can, for example, iliac cholangiocarcinomas, we have big difficulties sometimes to get a good sample, to have a pathologic report, and we have often problems with high bilirubin levels, and this could be a handicap to give this neoadjuvant treatment.
And to date, with that information, we can say that there is a group of patients that we can select for neoadjuvant therapy, maybe high tumoral markers, I don't know, some vascular invasion. Could be some facts that we need to give them neoadjuvant therapy first?
Yes, I would say that there are patients with high risk factors. that like in pancreatic cancer, that we are giving an adjuvant treatment before surgery. But so I think, for example, lymph node involvement could be one, vascular invasion. Also, tumor markers is more difficult because we don't have the threshold defined, but of course a high level of CA19-9 is a marker of distant metastasis, and I think that should also be considered to give those patients adjuvant treatment.
And to date, I think the gem splatting is just the
yes, yes, as it is the standard for first line treatment. I would, and when we know from retrospective studies that multi-agent chemotherapy is the best option, I would give this combination.
Great, thanks a lot, Elena.
Thank you.
That's amazing. So let's give Dr. Cellini the floor for his radiation oncologist from OMPU. So yes, the floor is yours.
Thank you so much. Thanks for the invitation and the chance to join this very nice webinar to the HESO and the HESTRO as well. So I would go over the topic in terms of the perspective of radiation therapy. This is the outline of what we are dealing with. A very brief introduction is absolutely important to focus, according to me, on this bile tract cancers, and particularly as also overviewed by the perfect presentation of Helena, and by some investigation and literature, because it still should be even more deepened, also due to the, as we have already heard, the incidence rising and the level that in the Europe we are getting of the incidence of this lesion. I will mainly focus on the intrahepatic lesions that has been proven, as we heard, to be at an increased incidence, so expected to be more to be faced, but also because some peculiarity of the anatomy and behavior could be of peculiar interest for radiation oncologist perspective. Unfortunately, there is not still that much in terms of evidences, and so we have to struggle a little bit, and radiation therapy is controversial. That's why you can see I have an escape here just in case of emergency if the films turn out too bad for radiation therapy. But jokes apart, I will start describing what is actually reported into guidelines, international guidelines, for instance, starting from the ESMO. This is about 2016, but has not been updated later on. So more or less the feeling remains that the role, as you see, of radiation therapy is at least unclear. There are some comparative trials, mostly focused on radiation therapy in combination with chemotherapy, so chemoradiation with quite high doses versus the chemotherapy alone, and that did not provide a real impact in terms of outcomes. But the authors of the guidelines address that probably dose escalation that brings us to the concept of stereotactic ablative radiation therapy can change the game. This is the outline, as we can see right now, of the suggested pattern. So for early stage surgery and possibly adjuvant chemoradiation, for instance, but for locally advanced, first starting with chemotherapy and then use local regional therapies as alternative or through the flow for those patients. We can go in deep to a little bit even earlier guideline, but mainly focus on intrahepatic cholangiocarcinomas. Again, the paper from Bridgewater confirms that radiation therapy has the role among the local regional treatments, including with transarterial chemoembolization or chemoinfusion or ablation, understanding the fact that sometimes, particularly for the intrahepatic cholangiocarcinoma, the rate of resectability is not always that high as we can expect. But anyway, also this guideline confirm that the role of radiotherapy has to be still investigated, let's say investigated. More or less in this SIR database analysis, which is not actually a meta-analysis, but applies for a huge number of patients, we see that the median overall survival for patient undergoing surgery and adjuvant, in this case, not preoperative, but adjuvant radiation therapy, can go up to 11 months at least. And that's quite interesting, at least comparable with the other modalities, and suggesting a role for combined approach. And this is the schema that the Bridgewater EASL guidelines suggest for managing this presentation, dealing with the fact that for intrahepatics presentation are less resectable sometimes, and so to use again adjuvant approach for the resected or non-curatively resected presentation, and reserve local therapy sometimes after or combined with chemo for the unresectable ones. But that is also worth for a consideration. Actually, the consideration that we have in terms of thinking of something that is applied before chemo, before surgery, a difference between neoadjuvant and definitive presentation converted to surgery. In other words, it means that if I have a resectable presentation or almost resectable in which I want to increase the result, is different than if I already have understood that this presentation is not at all surgically removed, and then I'm trying to do something to improve the resection rate. In this very nice review about the role of radiotherapy in biliary tract cancer in general, actually they have investigated, the group of Professor Gica investigated both the neoadjuvant approach of chemoradiation before resection, or even prior to liver transplantation. In both of the scenarios, actually, we see that very few was the representation of intrahepatic adenocarcinoma. So although nice results in terms of supportive preoperative inclusion into the multimodal workflow, that stands more for hepatic or distal lesion, or the one we were used to call as Glansky, or similarly to those approach for the perihilar or distal lesion. So very few investigation in terms of the intrahepatic, pure intrahepatic, and actually in this editorial of the Annals of Surgical Oncology, as Elena told us, most of the cases the preoperative approach stands for or is initially reserved for chemotherapy. So I'm going to outline you dealing with SBRT trial, if there is a role for this new modality of radiotherapy. Nowadays it's not anymore a new modality at all, and I only will talk to you about one trial, which is, according to me, quite representative of the mood of this presentation. Professor Giga again, which is a group with high experience in that, involved 37 patients with globally account for 43 lesions, in a certain percentage represented by intrahepatic cholangiocarcinomas, delivering an adequate dose in 3 to 12 fractions with quite a wide range, but anyway, with a higher, at least comparable, and somehow higher dose than the one that we can deliver with a prolonged so-called long course of chemoradiation. And we have to be aware that that's very important, because this is one of the peculiarity of SBRT, to be easily managed, merging it into a treatment course of chemotherapy, because only stands for 1 week basically. And with this in mind, with the limits that we are not only talking about intrahepatic lesion, but actually they got 14 months of median overall survival. We will see if it's too high or low in general, and I would suggest to do that by looking at some meta-analysis in 3 layers. The first meta-analysis I propose you is this JAMA published on JAMA meta-analysis from the group of Mavros, in which they selected trials for patients undergoing curative intent surgical treatment for basically intrahepatic cholangiocarcinoma. So a very huge number of patients, almost 5,000, as you can see, in which the median overall survival, if you have in mind the, the 14 months, in that case, the median overall survival for patient surgically resected was 28, so much better, but this is the best of the practice. Then I'm going to discuss with you the second meta-analysis that go deep into the approach of local treatment for intrahepatic presentations. Again, almost 4,000 patients, so it's a lot. Among the local therapies, it also includes, as you see, TACA or SIRT, all that stuff. But radiation therapy was represented by half of the cases of SBRT, but also regular conventional three-dimensional radiotherapy, and even small experience of 4 and 1 modality of proton therapy. Proton therapy and carbon ions means more or less the same family of alternative schedule. We will go deeper into that in a while. So with that in mind, we can see that, again, ablation had a very good result, but also radiation therapy provided in a very various approach, so not homogeneous, was almost 20 months, which is not that bad. And particularly, I want to highlight for you this meta-analysis by an Italian group from Bologna, the group of Professor Morganti. First name is Dr. Bisello, but only focused on, in a meta-analysis by a systematic review based on Prisma search, on trials addressed by SBRT into inoperable, upfront inoperable patient with intrahepatic colorectal cholangiocarcinomas. And so a much smaller number, but it's very highly selected. Mostly of the cases was as a salvage treatment, having most of the patients received other local therapies, not only chemo, and not be suitable for radiotherapy. And here, again, we see this 14 months of median overall survival, which is not that bad, actually. So it's a good outline. We can see if peculiar technologies in the 5 remaining minutes can aid something for us. Since not all the attendees are radiation oncologists, few words describing what is SBRT, stereotactic body radiation therapy, is a very high precision treatment, but deliver much higher dose per fraction rather than conventional, in terms of sometimes 5 to 10 times the same fraction of dose that we deliver in one single treatment, daily treatment over a long course of chemoradiation, so 5 to 10 times, and inducing a much more higher biological equivalent dose. In other words, if I deliver 2 grays per day up to 10 grays in a week, is completely different the biological effect that I can produce if I deliver the same 10 grays in one single day. And the dose distribution must be very tuned. The blue lines are the very low doses, which almost do not affect the organs, but the hot lines, as the red and the yellow you can see here, really are the ones that can cure, but also make damages around. So very high precision. That is obtaining in what way? Sometimes we use some fiducial markers. This is, of course, for prostate cancer, but you can imagine that in lung or in any other approach that can be detected by imaging. That's why it's called image-guided radiation therapy. Applied imaging before, but also during the treatment to be sure. Some of those needles for some technologies are even some transponders, so can be also actively interact with the machine, letting the machine knows in what part of the flow of the respiratory circle the patient is in, and making the beam on when the part of the respiration, and so the motion, you can imagine this for a lung cancer, but also for the motion into a liver cancer, is in that specific position, and making the machine off when the respiratory circle is in the phase in which the target is most likely to be outside the point of the treatment. That make for us a very big change, because if you don't have this, you have to imagine all the movement that the target can get, and so you have to irradiate a larger volume while you can really focus only on the target if you have those gating system. A very peculiar gating system is the very now fancy and on the wave practice of the MR guidance, which is a direct guidance that don't use some surrogates like this metal points, and that can show you with a very nice contrast of different tissues provided by MRI, and you can see very nicely how is focused the target, but not only that, also, I'm not sure if the video is going on, you can see the target while it's moving because that system is on through the whole treatment. The patient now is freely breathing, and we ask him to hold on his breath and to stop, so we reproduce exactly what we have planned for, and we can check it. And in case the red line, which is the target, moves outside, the machine stops. And this is not directed on transponders or fiducial, but direct to the target. Moreover, this peculiar machine is nowadays the single one, but other are coming in different modalities that can allow us, this is for pancreatic, but you can imagine also placed here for liver cancer, intrahepatic particular, which is very homogeneous in the surrounding tissue of the liver, but to readapt each day the plan of the day when you deliver that. On a long course, regular chemoradiation, the data that we first heard by myself and from Helena, that is 25, 30 daily fraction. You can't do this easily on each of them, but it's easy when you have to only do this for 1, 3, or 5 as BRT treatment. So each day you reload the patient, you refine the delineation. That's very important. Most of you, in 2 minutes I finish, so in 15 minutes global, most of you have heard about proton therapy. For the less familiar with that, all the energies I described to you right now were in the family of the photons. It's still X-rays and sort of energy, but if the photons, I told you that the blue line, the green line were the very low lines diffusing energies of low level all around the target. With protons, we can hit the target in a very much precise for dose distribution wave. And so for ray radiation or irradiation of peculiar sites is very important. Also, if you think to retreat the patient or treat the second lesion close to the other, but also the protons have a linear beam transferring of the energies. That means that hit the target somehow according to some counter stronger, and so make more damage to the tumor. Unfortunately, there is no still consolidated rather than few insights of single arm experience, sporadic experience. So I wouldn't build on this any conclusion, but it's actually very, very interesting. And I close with final additional insight that other imaging modalities, imaging is always very important for radiation oncologists, can be provided, for instance, from artificial intelligence algorithms that can predict toxicity. In this experience, this guy produced the software that learned automatically by a convolutional neural network from the previous treated patients in their same experience, which were the site of the liver for each patient more likely to be associated in the delivery of the treatment to a risk of damage, just to learn when they are planning with areas to be skipped by the dose distribution. And proton can also do something more in that regard, but also the use of nice new tracer for the PET CT scan has been shown in the preliminary experience to be associated to a dose response relationship between the radiation dose and the metabolic liver function. So to know how the liver is working and getting compliance with the treatment and maybe estimating the recovery of the tissue. And here we see this has been treated, this area, and before and right after we see that the shape of the area that is not working at the same level but can recover over time can be taken into account. So in conclusion, actually, although nowadays is more radiation therapy used for a salvage approach, can also be as a neoadjuvant for definitive approaches to conversion, to increase the conversion rate, or for neoadjuvants as well. And that BRT can provide a very interesting option in terms of efficacy and nicely imbricated with chemotherapy, so we can have both the advantage from both the technologies, the approaches, and new technologies really can help in that. Thank you for your attention.
Thanks a lot, Dr. Cellini. Very amazing talk also. 2 questions. We know that the cholangiocarcinoma is quite radiosensitive. So, and the intrahepatic cholangiocarcinoma usually appears with a very huge mass. Which is your experience in those signs in this kind of tumors before surgery, to reduce decrease in sight?
Actually, it's an excellent question. That's actually a point, because also makes it one of the threshold deciding wherever you can treat or not that lesion. Usually above 3 centimeters is so-called the boundary, that lesion above 3 centimeters are on the limits. But nowadays you can change it, and here again it can be nicely imbricated with chemotherapy, because you can do chemotherapy, reduce the size, and then go on and performing and letting the surgeon perform treatment. We have some experience also with bigger lesions. Actually, it's easier when you're nothing to lose, I would barely say. So if too big, up to 6 centimeters, taken from the experience of the primary HCC, hepatocellular carcinoma, and from the metastatic lesion, which is shared the experience of being basically, for our perspective, small spheres into an homogeneous organ. As long as we can keep the dose constraints, so the limit of dose threshold that we want to keep for the remnant liver function at a certain level, we can hit any lesion, and we can actually reduce that much. With modern techniques, we can also do a different dose levels into the core, the central core, which is usually less perfused, and so also more resistant to chemotherapy as well, and a smaller dose to the external part, so reducing the dose to the periphery of the tumor, which is the proximity to the liver. Not sure if I answered your question.
Yes, yeah, great. That's great. And second question, we have some experience using external beam radiotherapy in liver transplant setting for ileal cholangiocarcinoma. And we have one case with huge ulcer, gastric ulcer, that we can transplant it at the end. So there is some new papers that they go for SBRT because they give less dose of bigger dose of radiotherapy in less sessions. So what are your thoughts about that?
Again, it's a very hot topic. It's very important, because this is one of the opportunities that this new treatment has for. One is the imbrication with chemo, second is very fast, and the third is what you've just said. That's absolutely an opportunity. We don't have enough evidence base to say that it's on regular basis. That's why I started from guidelines description. It's not incorporated, but any of the guidelines says that there's no role, or only for palliative. They say that we must increase that. And talking about healer and more peripheral lesions, going to the ones we used to call the Klasky lesions, the far away we got from the liver, we also have different, because sometimes we are scared about using huge dose per fraction as BRT, because we are afraid to damage the bile duct. But in that case, we can also use the brachytherapy. So it's easier that we can go into the bile duct with a catheter, and that place a very precise dose distribution only locally, and that would reduce also the dose to the other organs. So we have different levels and approach of modalities for the treatment that really can help us as oncologists, radiation oncologist, surgeon, and medical oncologist, help us to really personalize the treatment, not only in the perspective of the not only, I mean, adding something to the personalization of the treatment in selecting the proper drug for the proper molecular profile, but also for the proper anatomical needs and behavior of the presentation.
Mm-hmm. Great, that was great. So just let's continue. Thanks, Dr. Cellini. Go with Dr. Manuel Ramia for the surgical point of view. Just the floor is yours. I think, Dr. Ramia, you are mute.
Now it's hearing me, yes?
Yeah, perfect.
Okay.
Now it's perfect.
Sorry for the problem. Okay, thank you for the invitation for the ESSO and also for the Spanish Society of Surgical Oncology called SEOC. Okay, I'm trying to talk about the surgical perspective. The topic is neoadjuvant. The information about neoadjuvant treatments and then surgery is very small, so I have to do more or less systematic review the situation of the surgical situation of the cholangiocarcinoma, speaking about neoadjuvant when I could. I have no disclosure, so other speakers said I'm going to focus in intrahepatic cholangiocarcinoma also and periocular cholangiocarcinoma that usually surgeons talk about Klatskin's tumor. I think that this is a not very common disease in Europe, only 2 or 1 or 2 cases by 100,000 inhabitants. So the experience of the Spanish or European groups in cholangiocarcinoma is not so high like in Eastern countries, but the cases are increasing every year. I remember that it was a very uncommon tumor when I was resident, and now a high volume center in Spain is doing more or less 10 cases that are not too much, but are a lot of cases if compared with 20 or 30 years before. I think that the problem is not only surgeons has a low experience in Europe, also radiologists, oncologists, radiotherapists, all medical doctors has not huge experience in these tumors. I think that the main problem of these tumors is the high unresectability rate. This is 65%, but in the cases we could do a resection, it's not more than a third of the cases. The R1, even R2 rate is very, very high. The surgery that we have to perform to take out the cholangiocarcinoma, especially hilar cholangiocarcinoma, are very demanding and usually are done in big centers and high volume centers, but are very, very complex usually. And sometimes you have to do or venous, even arterial resections. I think that it is important to remark that the large series are all from Asia. I think that the volume of patients treated in Asia is not the same that in Europe. And I think that it is a treatment by us because they have a very, very nice morbidity, mortality rate, and a very nice R1 rate that is not usually getting in Europe. I think that one of the most important problems now in 2021 that we are trying evidence surgery and evidence medicine is that the number of randomized controlled trial talking about surgery are very, very small. I think it's I could say there is no one, but perhaps I haven't not found, but I think that the numbers of RCT in surgical topic cholangiocarcinoma is near 0. So it's not I'm surgeon, but I think that we have to remark that in this year, actually, the best treatment for resectable cases is surgery, but as I have said before, the option to resect is low. I'm going to talk about some preoperative tricks. This is not a surgical topic, but I think it's very important for surgeons. I think that one question would be how to diagnose resectability. And I think that nowadays it's necessary to mix not only one diagnostic method. You have to do a CT, an MRI, and sometimes ultrasound endoscopy to take biopsy. So it's very important to combine all possible diagnostic methods to take the patient with the best preoperative information you could get. Sometimes in these complex surgeries, also we do 3-modal reconstructions to know if there is a mandatory to make a resection, a venous or arterial resection. How to train the patients, but all the speakers has talked about the problem of jaundice. Nowadays, there is some systematic review that has demonstrated that percutaneous transhepatic cholangiography is the best method to do the drainage of the jaundice. But in Spain, the main problem is these patients usually are managed by digestive departments, and it's very common that patients has an RCP, not a PTC, before surgery. But especially ASEAN centers recommend to do a PTC, not RCP, because the risk of cholangitis is higher than when you do a RCP. How to get enough liver remnant for the future preparative is another problem. Usually these patients, you have to do a trisectionectomy that more or less is 70% of the liver, and sometimes you need more volume for the postoperative period. And the main weapon we have is percutaneous embolization of the portal vein embolization made by a radiologist. It's a reduction of mortality if you do a percutaneous portal vein embolization, because if you don't that, sometimes you get involved in a problem in the operating room, because you find that you need more volume and you have cut the liver. So it's important to do a special nice planification of the surgery. How to evaluate patients after neoadjuvant chemoradiotherapy? There is no answer for this question. I think it's one of the most important problems. Neoadjuvant chemotherapy, in my opinion, is a very, very nice idea, and I think and I hope that possibly in the next years we do for many patients. Now it's a very, very selected group of patients, but it's very difficult to clarify if there is a correct or a good response to chemo or radiotherapy in these cases, because sometimes there is a reduction of the volume, but there is no clear RECIST criteria to know if there is a response in these cases. And the use of station laparoscopy is still a problem and a matter of debate. I think I have made 8 questions about surgical problems in hilar cholangiocarcinoma, and there is these 8 questions, and I'm going to tell my opinion about these questions. First question: is liver resection always necessary to treat cholangiocarcinoma? I think that if you are in front of a type 3 or type 4 hilar cholangiocarcinoma, liver resection with bile duct resection is mandatory. But there is a multi-institutional database with 257 patients demonstrating that in cases in the BISMID-1 and BISMID-2 patients, it's not necessary to do a resection, a liver resection. I think that more or less the results in the liver resection group and no liver resection group are very, very similar. So my messages for home is, remember, if you have a type 3 or type 4 cholangiocarcinoma, hilar cholangiocarcinoma, you have to do a liver resection. But if you have a type 1 or type 2, it's not mandatory to do a liver resection. The second question would be if you have to do a caudate resection in any patient. There is a meta-analysis of our journal, a European Journal of Surgical Oncology, the journal of this society, comparing the caudate resection versus no caudate resection in hilar cholangiocarcinoma. There was no difference in the morbidity and the morbidity or mortality of the patients when we combine caudate resection or not, but there was a higher incidence of radical resection, I want to say R0 resection, and longer survival in the group of caudate resection. So now in this year, you have to do not only liver resection, also caudate lobectomy, include when you perform the liver resection in every patient doing a hilar cholangiocarcinoma resection. Third, I think it's a little absurd because there is information about if you have to do left or right hepatectomy when you have a cholangiocarcinoma, Of course, the conclusion is if the cholangiocarcinoma is in the left side, you have to do a left hepatectomy, and if the cholangiocarcinoma is in the right side, you have to do a right hepatectomy. But there are some interesting points in this meta-analysis. The ER0 resection is the same for the two groups. You have to remember is this an anatomy landmark that left bile duct is longer than right bile duct, but when the left hepatectomy is done, the time for surgery is longer than when you do a right hepatectomy. It sounds a little bit strange, but it's logical because to do a reconstruction of the bile duct of the right side is more difficult than in the left side. So the problem is not the right or left hepatectomy. The problem of time is associated with the type of reconstruction. So the decision to do a left or right is only where the tumor is. Another question would be if ex vivo surgery with liver autotransplantation has a role in the 2021. There's a systematic review in the journal Surgery in 2020. And there are a lot of diseases included, but the 23 patients are hepatic cholangiocarcinoma in the hilar plate. Is the 10% of the patients. The median age was 54 years. All were single tumors. Both lobes were involved in 18 of the 23 patients, and vascular involvement was in 21 of 23. But I think that the bad idea of this technique is the mortality at 30 days mortality is near 20%. I think that nowadays in this year, you cannot offer surgery with a 20% mortality because there is another options like radio or chemotherapy that perhaps are not so good as surgery, but the mortality is not the same. So there was 12 months survivors. When you get surgery without a mortality, the results are not bad. But I think that it's my opinion that the high morbidity, even in experienced centers, made that this technique should be or avoided or do only in very selected cases. The ALPS for cholangiocarcinoma, I think there's not absolute contraindication, but I will read the sentence of the systematic review published in HPV in 2017. That is the outcomes for of ALPS for perihilar cholangiocarcinoma are inferior to standard resection in high-risk patients. So portal vein embolization should remain the preferred method to increase future renal liver volume in patients with cholangiocarcinoma. So ALPS is not now recommended as third option for perihilar cholangiocarcinoma. Some people will say, I do it. Okay, you do it, and it's not absolute contraindication, but I think that it's not a good idea. Finally, liver transplantation, not finally, sorry, there is 2 slides more. Liver transplantation in hilar cholangiocarcinoma, that is a topic that all liver transplantation surgeons like me and Christina likes a lot. To remember, the first cases were done in Mayo Clinic in 2000 with a very strict protocol with transplantation chemoradiotherapy. Is considered now experimental treatment. It's not admitted in all countries, in all European countries. And in Spain, we are doing now a very strict protocol to do a nice RCT to demonstrate if it's useful or not. But in 2020, in Annals of Surgery was published a meta-analysis with 428 patients. There is no RCT about it. And the survival rates are good and the recurrence rate are good. But the problem is you have to select so much the patients that is not an option for everyone. I think that the feasibility and the results and the safety is nice in liver transplantation for hilar cholangiocarcinoma, but the applicability, the number of patients that you could do it is very small. For surgeons in last years, morbidity and mortality, the results are becoming essential in our clinical practice. So I want to remark also the results obtained with surgery. There is a systematic review in surgery journal in 2019. There was include 51 studies, and the mortality was at 30 days was 5% and 90 days was 9%. The morbidity was very high, 57%. But I think that we have to remark again the difference between Western and Eastern studies. It's incredible, but the difference are so high, like the mortality in Europe is 8% and in Asia is only 2%. There are some jokes that the Asian people is thinner than American, European patients, but I think that experience in this disease is crucial to obtain, and the volume of the centers. Some center in Japan has operated more than 500 patients, and I think it's impossible to get a center like this in Europe or in USA. And I think that the results are linked to the experience. So my remark or my home messages is the mortality is high, the morbidity is even higher, and to remark again the excellent results get in Asia. I have 3 slides about intrahepatic cholangiocarcinoma. I think I ask if I do it or is too much time. What is your opinion?
Go ahead.
Okay, I have done the same idea. What questions I have for intrahepatic cholangiocarcinoma? My first question was a lymph node dissection. And the resume was that the lymph node dissection don't affect the survival, but is affected or associated, with increased postoperative morbidity. So now it's not mandatory to do a hilar lymphadenectomy in the cases you are doing a resection of intrahepatic cholangiocarcinoma, because morbidity is higher and the results of survival are the same. My second question was, is laparoscopic approach is nice and adequate for intrahepatic cholangiocarcinoma? There is a systematic review of 2021 in American Journal of Surgery. And the results is that the results obtained with laparoscopic are worse than the results obtained with open surgery. And the recommendation of this systematic review is only to do by very experienced surgeons. The experience in laparoscopic liver surgery is related to results, and in these cases that are usually tough, it's more important to have a very high experience in HPV and liver laparoscopic surgery to get the same results than with open surgery. So the recommendation is, if you are not very skilled in laparoscopic liver surgery, do it open. And finally, liver transplantation in intrahepatic cholangiocarcinoma is not the same situation that with hilar cholangiocarcinoma. There is a systematic review in transplantation in 2021. The results are not bad, but the recommendation is that in cirrhotics that you incidentally found intrahepatic cholangiocarcinoma, the results are similar to patients only with cirrhosis. But when the tumor is bigger than 2 centimeters, the results decrease the survival and the relapse increase quickly. So you have to select very well the cases. And if you have you know preoperatively that you have a intrahepatic cholangiocarcinoma, you have to select the patient for doing a liver transplantation. I think that the same problem that with hilar cholangiocarcinoma is that intrahepatic cholangiocarcinoma in Europe is an unusual disease, and we have not enough experience to define a clear criteria for when we know preoperatively that we have intrahepatic cholangiocarcinoma, if we have to resect or to transplant. So I think that it's very important that in this paper remarks that possibly neoadjuvant therapy under research protocols would be the way to improve the results obtained with liver transplantation with intrahepatic cholangiocarcinoma. And that's all. And I haven't asked adequately the question about surgery and neoadjuvant therapy because there is very few papers, and I try to do nice, I hope, review about cholangiocarcinoma surgery in 2021. Thank you very much.
Thanks a lot, Dr. Ramia, for sure, very good review. If anyone in the audience has questions, please go to Q&A and I will read the question for you. So, Dr. Ramia, I agree with everything, almost with one point. For sure, the survival in these patients is going to depend to achieve early one resection. So in the cases of biliary cholangiocarcinoma, no, stage 1, stage 2, radiological looks like it's a stage 1 or stage 2, but you need to be prepared if intraoperative, you have positive margin after resection of the bile duct. So maybe you have to increase a left or right hepatectomy. So I think it's a good point to do a liver resection in bismuth 1 or 2 biliary cholangiocarcinoma. I don't know what you think.
I think that bismuth 1 or 2 it's nice to talk about it, but there are very few cases. You have a lot of experience in cholangiocarcinoma, and there is no too much class scheme, but there is even less cases 1 or 2. I think in case 1, in bismuth 1, that is in the middle of bile duct with you have 3 or 4 centimeters up and down, and you could do a liver bile duct resection and an hepatogeniostomy. I think that when you are in the surgical theater to decide if we are in front of a 2 or 3A or 3B is not easy. And I think that the most important is to get our zero resection. So if there is it's necessary to do a liver resection, you don't have to doubt about it, because you know that the possibility of getting a good survival is linked to R1 or R0 resection. And I think it's important to do a caudate resection also, because as you know, the bile duct of the caudate lobe is entering in the lower part of the hilar plate, and perhaps is one of the problems is you are doing a R0 resection in both intrahepatic bile ducts, but there is a positive margin in the caudate lobe. So I think level 1 or bismuth 1, okay, bismuth 2, you are I think the same doubts of you.
Okay, so let's go just for the clinical case. 5 minutes, maybe a little bit more, just to see if we are agreeing with what you have explained. This case is one of our case, for sure, could be many thoughts. It's difficult to treat the cholangiocarcinoma, and that's why I was keeping saying we need to obtain R01 resection. So just any thoughts? Let's start. This is a 73-year-old female. Okay, let's see. With, let me, because otherwise, okay, arterial hypertension. So because she did a blood test, conventional blood test, the doctor found this liver dysfunction, mild liver dysfunction. Ultrasound was performed, and they diagnosed liver mass, 11 centimeters of liver tumor, with normal tumor markers. So she was referred to our hospital, and we performed this MRI. As you can see, there is a huge tumor very close to the right hepatic vein, with no free liver remain, just only the posterior segments. and with not vascular invasion in the hepatic ileum. So we perform a liver biopsy, which shows intrahepatic cholangiocarcinoma. And Elena, if you want to talk about this panel of biomarkers, that I think they did it after liver biopsy. So, Elena?
Yes.
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 So just try to explain us what that means.
Yes.
Because for us,
Yes. This should be a Foundation 1 test. And in the left side, you have the pathogenic molecular alteration that the tumor has. From those, I would remark the ADH1 mutation that is present in a 20% of the cases of cholangiocarcinoma, and in which, as I explained, we have a positive phase 3 clinical trial for second or third line. And also there is a CDKN2A loss and CDKN2B loss that are alterations from cellular cycle. It's also the tumor mutational burden and the microsatellite instability that is a marker of response to immunotherapy. Both are negative. And in the right side of the slide, you can see the variants of unknown significance. So these are variants from that we cannot say that are pathogenic. So we cannot generalize, use it in a generalized way to treat the patient.
So they can say if we are in front of aggressive or not aggressive intrahepatic cholangiocarcinoma.
So we have no data to say from the molecular analysis, we cannot say that this is aggressive or not aggressive. Okay. So we don't have this data.
It's just for maybe target therapies, no?
Yes, yes, yes.
So we perform a CT scan. We didn't show extrahepatic disease. So what is next? We are in front of intrahepatic borderline resectable. Remember that it's only the posterior segment free, with normal tumor marker, no satellitosis, no extrahepatic disease. And for us, for sure, no sufficient future liver remnant to guarantee a resection because it was too close to right hepatic vein that we need to preserve if we want to proceed with surgery. So what will we do? Chemotherapy and surgical resection, chemotherapy combined with local regional therapies as SBRT plus surgical resection, or chemotherapy plus liver transplantation. I don't know if someone in the panel will recommend or will go front with surgery up front with no chemotherapy. Just a question for all of you. No.
I want to remark the very nice immunohistochemical analysis. This is the way you do every case.
Yes, I can tell you.
No, my congratulations.
So. Sorry, this is an NGS panel. So we do in almost all cases. So we recommend to do this NGS analysis in all cholangiocarcinoma patients, as we can find some molecular targets that can guide us with future treatments for the patients.
Perfect. Right. My option, chemotherapy plus surgical resection. Why did I choose it? Because I have no liver, no remnant, enough remnant for doing surgery directly.
Okay.
Can I ask you?
Yeah.
I would neither, of course, recommend radiation therapy in this case, unless the patient could have symptoms, because such a wide and big lesion could also make a distension of the capsula that could affect with symptoms, and maybe analgesics cannot be enough, but otherwise I wouldn't do that. And a question for my counterpart of surgeon, would you be, since the remnant liver is too few, would you be concerned in case of dramatic reduction of the volume due to toxicity induced by chemotherapy into the remnant liver, because we assume that the remnant liver now is few, so we cannot dissect it. Would be the surgeon's concerned in case the lesion decreased, but the remnant liver could be affected by the toxic of chemo?
Not really, but maybe in this case, I would let you know what we did. Maybe in this case, I was concerned about the R0 because it was too close to right hepatic vein. I will show you later, it was enough future liver remnant, but I was concerned if maybe with some combined local regional therapies as VRT could downside a little bit the tumor. I think it could help in this case. Wherever,
yeah, sure. Maybe not at this stage. My ideal flow would be to restage at the mid time of the expected course of chemo. So not right at this stage if there is no symptoms, so we are not forced to that, and see if the medical oncologists want a complete long course of chemo right in the middle, if we can restage the patient.
So go ahead. We decide for chemotherapy as surgical resection. Maybe we miss that you said, Francesco, just to restate. We did that patient cisplatin gemcitabine 5 cycles, decreasing side a little bit, 11 by 9 centimeters to 11 by 7 centimeters, with no extrahepatic disease. We now are performing the pathobiliary scintigraphy just to check not just the percentage of future liver remnant, but also the volume. And both were far enough. Just the future liver remnant, more than 40%. And the function has to be this ratio more than 3, and was 5.2. So we decide go for surgery. This is the video after restaging after these 5 cycles. Looks like it's a little bit separated from the right hepatic vein, a little bit decreased inside, with no vascular invasion also. We did a 3D reconstruction just to check there is the right side, posterior right side free. This is the images of liver function, the remnant liver function, that looks very nice. It's very, very useful for us. So then we perform this left hepatic trisectionectomy with lymphadenectomy. In this case, Dr. Ramia, in intrahepatic cholangiocarcinoma, we do it routinely because it's not going to improve the survival. It's just for a staging of this tumor, no? The histology came as moderate differentiated cholangiocarcinoma, P2 and 0 with microvascular invasion. And as you see, there was a minimum tumor margin. The distance from tumor to the margin was less than 1 millimeter that we consider R1. So I think in this case, maybe some SBRT trying to reduce a little bit the tumor could be helpful, because after that, the patient doing well after the first week after surgery, but 2 weeks after surgery started with abdominal pain, fever. Maybe we missed that during the surgery, but there was a lesion of the posterior bile duct. You can see the cement 6 duct and cement 7 duct completely separated. That was a very complex bile duct that I think it took 3 months in healing. For the reason the patient couldn't receive no more adjuvant chemotherapy. So just what we did wrong, maybe we should perform another strategy in this case. For sure, the chemotherapy was helpful, but maybe we make a mistake just not to associate some local regional therapy or even transplantation. In this case, we don't have the protocol for intrahepatic cholangiocarcinoma, but for sure the R1 resection is not going to be helpful in this case, and mainly because she cannot receive any longer chemotherapy after that. So any thoughts? There's no common case, but for sure, each of us, we can have a similar case.
May I do a comment, Christina?
Yes, for sure.
I wouldn't say any mistake. Actually, you did apply, according to me, but we will listen to the colleague, you did apply the guidelines, actually. So it's not a mistake at all. There is always the concern if you can do something more, which is personalization, but you also have to be aware when you do something more, but if you go outside the guideline, you also risk. And so if you're not enough supported, I perfectly understand. So according to me, no mistake. Two alternative options could be a reevaluation at the mid or before the end of the chemo course, because in this case, it didn't shrink that much. It did a good response, but not enough. In case there is still a big lesion, you can run for chemoradiation, which is smaller doses, but it prolongs. But anyway, if you're not going for surgery anyway, you can have 1 more month. But if it's not too much big, you can run for ASBRT. If you want to really personalize, you can even personalize patient by patient. So focusing the higher part of the dose delivered into the more needed part. For our perspective, for instance, differently than for ablation, the closeness, the relatively closeness of the vessel is not a big issue. While for the ablation, the needle is actually always freaking by the closeness of the vessels. So you can also concentrate higher ASBRT dose close to that part, and so look for more distance and maybe have an answer. But still, that is not supported by enough evidence base to be outside, to be other than a personalization. I used to call that personalized approach, which is good clinical practice, but very specific. So I guess you did very well, but you can also try something less. A posteriori is always easier.
Yeah, always. For the reason I choose this case. Dr. Rami, any thoughts? Or Elena, yes?
Yes, I have only one thought, is that we don't know how much chemotherapy we have to give to our patients. So before surgery. So in this case, 5 cycles are like 4 months or something like this. So an option could be to give 6 months of induction chemotherapy and see if the tumor decreases a little bit more the size.
Great. Dr. Rami?
My comment is philosophical. I think that the surgeons, it's curious that the surgeons are most involved or most excited with neoadjuvant treatments than oncologists sometimes. We know that these patients are very difficult in the operating theater. So, and the possibility of having a high level of a high percentage of morbidity, of severe morbidity, like this case or many cases, postoperative liver failure, high output biliary fistula is very high. So the possibility of receiving adjuvant treatment after surgery sometimes is delayed 1, 2, 3 months. So that's why surgeons insist so much in the multidisciplinary teams committee to give neoadjuvant treatment, but sometimes it's fighting about with oncologists to do oncological treatment. So it's a little bit funny, no? I think that is a very typical case. You have done everything correct and perfect, but the morbidity in this patient is very high because technically are very, very difficult patients. And I think that immunotherapy, all the radiotherapy options that Professor Cellini has explained nicely to us, I think that would be the next step to do a tailoring patient treatment. So I think in the future, most of the patients would receive some type of neoadjuvant chemoradiotherapy, and surgery will be at the end, but with the treatment, all receive the treatment before, because morbidity will be high always, because it's very difficult to operate these patients.
So thanks a lot. Just came to the end. There is no questions from the audience. I hope you enjoy and you could learn a lot from these beautiful topics. So thanks a lot for everybody.